Voy a dar introducción a nuestro primer orador, que es el profesor Jürgen Rockström. Jürgen, thank you very much for being here with us today. I'm going to give your bio sketch in Spanish for the audience. El profesor Rockström, que pienso que todos lo conocemos, es el jefe de la unidad de la clínica VIH ambulatoria en la Universidad de Bonn, donde completó su formación médica. Y como todos sabemos, ha estado involucrado en investigación en muchos aspectos del VIH, tratamiento antirretroviral, tratamiento de las coinfecciones víricas por virus hepatotropos y más recientemente en la infección por COVID, de lo cual ha sido investigador principal de numerosos ensayos clínicos y proyectos. Es autor de cerca de 800 publicaciones indexadas en PubMed y más de 100 capítulos de libros. Y desde el punto de vista de sociedades científicas ha sido presidente de la Sociedad Alemana de SIDA, desde el 2009 miembro del Comité Ejecutivo de la EAX, de la Sociedad Europea de SIDA, con quien organizamos en forma conjunta esta mesa. Desde el 2011 miembro del Governing Council de la Sociedad Internacional de SIDA, head del panel de coinfecciones entre el 2008 y el 2017 de la EAX, presidente de la EAX entre el 2019 y el 2020 y actualmente nuevo chair de las guías en su conjunto. So Jürgen, thank you very much for being here. He's really a great expert in this topic, and I think it's going to be very interesting to listen to you in this presentation.
Buenos dias a todo. It's great to see that my bio in Spanish is much shorter than in other languages. No, just kidding. So my Spanish has not improved over the last 10 years, so unfortunately, I will not be able to present this in Spanish. My task today is sort of to set the stage in this roundtable to give some aspects around epidemiology and the factors involved in the development of non-alcoholic fatty liver disease and NASH in people living with HIV. I sort of set up the talk to give a definition and have a look at risk factors for fatty liver disease, talk about the epidemiology, then how big is the problem really in people living with HIV and what are the clinical consequences of fatty liver disease. Now obviously, the definition of NAFLD is the evidence of steatosis, which should be present in more than 5% of hepatocytes detected by imaging techniques or histology. There are, on the one hand, secondary causes of fatty liver disease, most prominently alcohol abuse, but also drugs can contribute, steroids in particular, then there are hereditary disorders. Non-alcoholic fatty liver disease is therefore a diagnosis of exclusion of secondary causes and can either represent simple steatosis of the liver or, in the setting of histologic evidence of inflammation hepatocyte ballooning, be defined as NASH. Obviously, this represents most dominantly metabolic abnormalities, including obesity, diabetes, insulin resistance, hypertension, and dyslipidemia. Now, hepatic steatosis in the absence of a secondary cause, so in particular alcohol and steroids, that's what we then would consider simple steatosis. If you have the histologic evidence of ballooning inflammation, as shown here, this moves on to the stage of NASH, which then can move on to develop significant fibrosis and eventually cirrhosis. So clearly what you don't want is the development towards fibrosis in people with fatty liver disease. Now more recently, there was an attempt to have a new consensus statement on fatty liver disease and to come up with a potential different definition. And this is metabolic dysfunction-associated fatty liver disease. And the difference here is that alcohol consumption no longer plays the dominant role, so it's really the presence of hepatic steatosis, again, either by imaging techniques or blood markers, or by liver histology, and then people who qualify as being overweight by BMI categories immediately qualify for metabolic associated fatty liver disease. If you have type 2 diabetes, you also go the pathway down to MAFLD. And if you are lean or have normal body weight, then there should be the presence of at least 2 metabolic risk abnormalities, being an increased waist circumference, hypertension, lipid abnormalities, or pre-diabetes, insulin resistance, or signs of inflammation. So the move from NAFLD to MAFLD is really trying to establish a positive diagnosis caused by clear identifiable metabolic risk factors and not just have an exclusion diagnosis. The redefining of fatty liver disease here you see the current one would be NAFLD, ALD, and then the clinical complications being steatosis versus NASH. And here it's now adding sort of cryptogenic other reasons for fatty liver disease, which are separated from metabolic associated liver disease and alcohol consumption. And then there is an attempt to also move away a little bit from liver biopsy, but rather to markers of lipotoxicity, which is obviously needed because obviously liver biopsy is becoming less and less popular. Now, I have to say that when you talk to hepatologists, you get very mixed feedback. I would say that North America has not taken up this definition. This is a more European sort of developed classification. And so I don't know exactly how this is going to end up. And it makes science a little bit more complicated because some people use the one definition, some use the other definition, and there's no clear consensus. And obviously, when NAFLD was developed, there was very little data on NAFLD in the setting of HIV. So most of the data we have is really around NAFLD. So my first question to you is, how high is the prevalence of non-alcoholic fatty liver disease globally? I mean, is that a very huge problem? How many people are affected? Is it 10%, 15%, 25%, 35%, or more than 35%? Please vote now. There's no music, no? Guantanamera. Yeah, if you don't want me to sing, I was dropped out of the choir because my voice was not tolerable for the rest of the choir, but so they put me into theater group, which was not also very successful. So that's why I became a doctor in the end. So I don't know exactly how long we need to wait, but I think I'll just move on, see what happens. Oh, that's the white screen, okay. All right. All right, so there is a disparity of answers. I'm happy no one said 10%, so that's obviously very low. 25% is the correct answer, and that is the majority, so that's great. But you could also say, well, I voted E because I think in Arabia there is a prevalence of 35%, and you're almost right. So there are different representations. The highest rate is actually in Middle East, where there seem to be a particular risk for diabetes development, but you can see that overall it's 25% on a global scale. So clearly an emerging issue, and thinking of the trajectories of obesity development overall, with more and more people developing high BMIs, including myself, you will be very well appreciative of the fact that this is becoming an increasing issue. So 25% have fatty liver disease, which per se does not necessarily mean, though, that that will have necessarily an overall dimensional impact on overall clinical outcome. But if it moves on to significant inflammation, hepatocyte ballooning, then that seems to be a more dimensional clinical course. And you can see that resembles, though, a much smaller proportion of only 3 to 5%. And you can see that of those, then again, only 1 to 2% are at risk of developing really severe complications of fibrosis and cirrhosis. So this is still in low numbers, but don't forget that obviously it's dependent on the time you have fatty liver disease. So the question is, how is that going to evolve over time as more and more people develop fatty liver disease, and is that going to increase over time? You can see that the prevalence in HIV has always been somewhat higher. So the prevalence for NAFLD and HIV has ranged between 28 and 55%, obviously a little bit biased by which population you're looking at. NAFLD or NASH was found to be around 10% and 4% at risk of cirrhosis. Now, it's a little difficult because there are other risk factors as well in the setting of people living with HIV, but remember that HIV per se can also infect hepatocytes, can lead to inflammation. If you see someone during seroconversion, you often find elevated liver enzymes, or even in people who are untreated. So there seems to be something also happening with the liver, and that initial inflammation may actually contribute to a more dimensional outcome of fatty liver disease. So how big is the problem in people living with HIV? And there have been various studies, and I think it's important to look at different studies because you saw from the world map of NAFLD that there are differences between South America and Middle East and so forth. So it's good that we have some Asian data, some South American data, some North American data, and some European data as a sort of a representation of various continents. But you can see that overall the prevalence is high even in Thailand, with 32% up to 31% in Germans who enjoy attending the Oktoberfest. So there are obviously differences, but not too much. And in general, I think we would all agree, NAFLD seems to be a clinical entity frequently found in people living with HIV. Now, having that said, the question then becomes, and that's what I'm going to ask you, which are the crucial factors in contributing to the development of hepatic steatosis? Is it TAF and or integrase inhibitor use? Is it waist circumference? Is it diabetes? Is it maybe just 2 and 3, or is it all of the above? Please vote now. All right, so the majority said it is waist circumference and diabetes, which is true, but almost half say it's all of the above. So maybe is there also a role for TAF and integrase inhibitor use? And I think that is probably one of the more impending clinical research questions we currently have. And don't forget that many of the studies which looked at risk factors, you can see this from the publication from Dr. Maurice in 2017, was before the introduction of TAF and integrase, so that will not have an impact in this particular analysis. So the traditional risk factors really are very similar to people who don't live with HIV, which is a high BMI, waist circumference, insulin resistance, development of diabetes, hypertension, dyslipidemia, and interestingly was also associated with a higher CD4 count, whereas suppression of viral load, duration of HIV, and CD4 nadir and duration of heart did not play a role. So that makes, I think, the story somewhat a little bit more complicated, but remember, we use different drugs, and I think that's one of the big issues you have when you look in the literature about reports on presence of hepatic steatosis. It's very much impact on which time area you're looking at, because remember, there was also a time when we used a lot of DDI and D4T, which we all know independently by contributing to mitochondrial toxicity, actually led to liver enlargement, hepatomegaly, with hepatic steatosis. That was a hallmark of mitochondrial toxicity. So we're not using these drugs anymore, we're using other drugs, and sometimes it becomes difficult to separate all these different effects. Now, in individuals who present with non-alcoholic fatty liver disease, the question then becomes, so if you look at individuals who have suggestive fatty liver disease, have elevated liver enzymes, and you then perform further diagnostic workup, in particular liver biopsy, how many of them have NASH or fibrosis? And in those studies, and remember again, this is 5 years ago when that was published, so add 2 years before, so 7 years when this data was generated, you can see that the prevalence of people who had NAFLD of NASH was very high, with 41% and 21% having significant fibrosis. So I think that is a very important message, and you'll hear more about how to diagnose and follow up patients in the subsequent talks. I just want to say this is a real concern. I always think of a patient I saw from a lady who sent the patient because she had the feeling something was happening. He was already pre-diabetic. He had platelets of 50,000. So if you never perform any kind of liver test regarding fibrosis development, if someone has 50,000 platelets and it's not HIV-induced thrombopenia, then you have a real issue, because according to many scores, you will see in the APRI score they have cirrhosis. And that was exactly what happened. So he already had cirrhosis on first consultation and had obviously advanced fatty liver disease. So this is something which people are seeing but don't realize, even though with simple tests you can diagnose that, and that's very important, because I think we're missing out a lot of patients with advanced disease stages. Now, Dr. Maurice who's working in Germany now, interestingly, in Mainz and Heidelberg, has looked at prevalence and risk factors of NAFLD in a smaller HIV cohort more recently, and he tried to, again, look at risk factors and independent predictors of NAFLD and significant fibrosis, and he did this also with the newly introduced FAST score. So the FAST score is another non-invasive kind of marker, which includes transient elastography, measurement of the steatosis content by CAP, the liver stiffness by FibroScan, and also liver enzymes. So it's an easy task if you have a FibroScan device to calculate, and he found hepatic steatosis by 35%, again, very much resembling the data I showed you before. And he also showed that the FAST score was helpful in identifying individuals with fibrosis. And you can see that the independent, most highest risk factor associated with fibrosis development was actually type 2 diabetes. And for NAFLD, it was actually increase in weight circumference. Now, in our own cohort, we've been looking at the long-term progression of fatty liver disease because, remember, this is something which will evolve over time. This is nothing which happens over several months. It will take years to develop. And as such, we felt it might make sense to take a cohort of people living with HIV where you exclude all those who have hepatitis B or C co-infection, include those with overt admitted alcohol abuse, which is obviously always a limitation because most people don't say that they are drinking, and then follow them up over time. They receive an annual FibroScan and CAP measurement, plus storage of blood samples. And you can see that when this paper was written, there was a median follow-up of 41 months. And you can see that indeed, by those who included, there was already a significant proportion with higher steatosis stages, S2, S3 of around 30%, very much resembling the overall NAFLD prevalence we've seen so far from other studies. But when you look at the last visit, you can see that that has increased now to 45%. So there is a clear progression to more fatty liver disease over time. We also looked at the FAST score because that was newly introduced and wanted to see how does that perform in HIV patients. You can also see that those who had a cutoff above 0.35, which is the cutoff for suggestion of more advanced issues, is also increasing over time. So there are obviously invasive markers which allow you to show something around the long-term progression. And what was new in this paper was that we sort of looked at specifically the impact of newer antiretrovirals on the risk for steatosis progression. And you can see that in this particular analysis, the use of integrase inhibitors as well as TAF was associated with a higher risk for steatosis progression. And I think that is sort of the bottom line question. How is this all going to end? And obviously this was strongly correlated to an increase in weight gain. So if waist circumference plays a role, obviously weight gain will lead to a change in waist circumference, and that may have an impact overall. Interestingly, those who were on TDF were protected against steatosis progression and may underline the immune suppressive effect of TDF altogether. Now, Giovanni, who's always a driver in making research even better, has animated the Canadian cohort and our cohort to put their data together with his Modena cohort and to look at different groups of individuals, more specifically looking at the impact of individual drugs. And this was presented by one of his wonderful colleagues at the Glasgow meeting. And you can see that factors associated with the risk of progression from no MAFLD to MAFLD or regression from MAFLD to no MAFLD was linked with age. Men seemed to be protected. That may underline some of the findings from the advance where women seem to be at higher risk for weight gain in general. And obviously weight was an issue for increase in MAFLD progression, which I think makes perfect sense. And with regard to drugs, he could not find in this large cohort a correlation between integrase alone or TAF alone, but the combination of two was associated with an increased risk. So there seems to be at least some signal. I think we sort of have to dissect why is that appearing in the combination, what are the reasons, or is it if I take TDF, for example, with integrase, is the story different because of a weight suppressive agent with a weight potentially gaining agent, and how does that all play in? I think there's still more work needed to understand where this is all going, but I think it highlights that if we want to continue using integrase as the preferred initial regimen, we will have to collect data more rigorously on fatty liver disease under consideration that this, in the end, may clinically quite relevant. So what are the consequences of hepatic steatosis? There are very few studies which are addressing that, and I think that is the big lack, and I think there is at least clear potential for establishing a fatty liver disease cohort, but you know that cohort funding in the setting of HIV is a very difficult issue these days. There are other emerging infectious diseases which have captured attention, and also taken away a lot of the research money. There's one very small study, and I just included because one of the very little studies which is out there looking at a median follow-up of 15 years, but it has a very small number of patients included. It was only 41 HIV mono-infected individuals. They had a control group of 28 healthy controls. And what they were able to show was that in this small cohort, at least, there was very little change in the amount of NAFLD fraction over time, and there was also no arising issue around more advanced fibrosis stages. The mortality due to NASH was very low, so they basically said, well, in this cohort, at least we don't have a big alarming signal. There was much more insulin resistance development, though, compared to healthy controls, and obviously we all know that HIV per se may contribute to the emergence of insulin resistance, and obviously the use of agents. So if you follow people for 15 years, you would at least speculate that some of them have received potentially first-generation protease inhibitors, which were associated with insulin resistance or similar agents. So I think it's an evolving story, but I think the question is still out there. Is this over time going to become more relevant? And one of the best ways to answer that is to look at transplant data, because transplant data obviously captures the reason for liver transplantation, and you would expect that just like in mono-infection, if people with hepatitis C are now being cured, and you may have seen patients who were on the transplant list, got treated with DAAs, got cured, and maybe stay on the list, but really there is no worsening of liver function and actually can stay on that list for very long. So I can tell you that the 3 individuals I have on the transplant list for over 6 years now, all have been cured, and none of them qualifies for liver transplantation because basically they're staying at a relatively stable stage and don't have a high enough MELD score to qualify for liver transplantation. Now, NASH has become the leading cause of liver transplantation in people who are not living with HIV in the United States. And this study, which was just published earlier in spring this year, looked at the different causes or indications for liver transplant in the United States in people living with HIV. And you can see, although this data only goes to 2018, that already there in black, the number of people qualifying for transplantation or receiving liver transplantation is mostly due to NASH at this time point already. So in the setting of people living with HIV, NASH has also become the most prominent cause of liver transplantation in the US. You can also see on the right-hand figure that indeed transplant centers performing liver transplantation in HIV co-infected individuals has increased over time. Remember, there was a lot of reluctance when hepatitis C was not treatable because of the almost 100% risk of reinfection and the diametrical course of hepatitis C after organ transplantation, where the setting of immune suppression for preventing organ rejection led to a faster fibrosis progression. But that has all changed. The outcome is now fantastic, but obviously hepatitis C can be treated, and the reason for liver transplantation in hepatitis C patients, fortunately, has disappeared, but NASH is becoming an increasing issue. So if that's the truth, then that means that NASH is prevalent in our population, and we'll need to monitor and treat them accordingly. So let me summarize. NAFLD is a common cause of chronic liver disease in HIV patients. I think there's an interesting ongoing discussion of definitions, and is MAFLD maybe a more positive definition rather than using exclusion, and that's something to discuss. But I would sort of cite David Thomas, who is the ID lead at Johns Hopkins, who in the general discussion about fibrosis assessment in people living with HIV said it doesn't really matter which definition or test you use, just do it. And I think that is the important message. It really doesn't matter, depends on what circumstances you work with, how reimbursement is for all these things, but to think about it and consider this a clinical relevant issue, I think, is probably the more important point here than getting too upset about which definition is used more favorably. Clearly, obesity and metabolic syndrome are key risk factors. I think just in line with all population trends, this is also hitting an aging HIV population. The MAFLD criteria clearly identify a more homogeneous condition than NAFLD, overcoming the difficulties and controversies and the definition of at-risk alcohol intake, which admittedly is difficult to assess. NAFLD will lead to liver complications, including cirrhosis, liver failure, and liver cancer, and probably even more importantly, most people with NASH-related issues probably die from cardiovascular complications even before the onset of liver decompensation, because that is very much increasing in this subset of individuals. So I think clearly is a pledge for longitudinal data on long-term outcomes, and I'm sure Giovanni has the energy to make that all happen. Thank you very much.
For your nice presentation on the definition and the new changes on the transition, and also the epidemiological characteristics and the potential consequences, and still the many gaps in there.